Hello and welcome guys. In this session we are going to discuss the recall question of NEET PG which was held in this month of May 2022, and I'm your ENT faculty Dr. Sanjay Aggarwal. Now a disclaimer here that we get the questions from the memory and recall of you students, so maybe the images are not the same and the choices may not be the same, but we are doing our best to discuss the questions that were asked in ENT, right? You understand that, isn't it? Okay, this is the first question. A young child presented with pain and hearing loss, otoscopy image is shown, identify the image. Now, various people have given me very different kind of questions. Somebody said that this is about image of the fluid in the middle ear. Some said this is about the swelling on the tympanic membrane. Some said there is air bubbles in the middle ear. Some said that it was a straightaway questions, that there are two different questions. Some said one is a language question like this, a clinical question, and some said that it is image-based questions, purely image-based questions. But I've just kept one question. Maybe there were two questions, I'm not too sure. So this particular image that I've chosen is air bubbles in the middle ear. And air bubbles in the middle ear is seen in glue ear, which is also called otitis media with effusion. So this is otitis media with effusion, which is also called serous otitis media, also called glue ear. It's an inflammatory disease of the middle ear which causes hearing loss in a young child, and it is due to station tube blockade, and the cause of the blockade of the station tube is usually adenoid. So adenoidectomy is done in these patients. Meningitis bullosa is a swelling on the tympanic membrane due to either viral infection or due to mycoplasma. Either it is viral, which is influenza virus, or mycoplasma. Some even say that it is due to streptococcus, and there is swelling on the tympanic membrane. I'll show you the image of that. And pneumotympanic means air in the middle ear. This air, excess air in middle ear is hemotympanum, and that's why there is a bulging tympanic membrane. So bulging tympanic membrane is very similar to pneumotympanum, right? Now look at the first image, is the one that I've shown you with the air bubbles in the middle ear. This is glue ear. The second one is meningitis bullosa. There is inflammation of the tympanic membrane with swelling on the tympanic membrane, meningitis bullosa. And this is pneumotympanum. As you can see, that tympanum means middle ear. So there is air in the middle ear which is pushing the tympanic, too much of air in the middle ear, either after Valsalva or after some procedure, and the station tube gets blocked and the air gets trapped in the middle ear, that pushes the tympanic membrane, bulging membrane, and this is how the pneumotympanum looks like. The bulging membrane also looks very similar. So this was one of the questions, and most probably the image that there is shown was either meningitis bullosa or pneumotympanum, but I chosen glue ear because that is the most common condition out of the three that is seen in a clinical practice. Okay, next question. Now this is from the PDF file of the eGurukul. Now all the questions that were asked in ENT were from the eGurukul app and the PDF file. So this is one of the proofs that I've shown you so many images of the tympanic membrane. Here if you see, this is congenital cholestoma, which looks very similar to the bulging of the tympanic membrane, and this is that bulging tympanic membrane. Then this is like fluid in the middle ear. So many images of tympanic membrane that you can see, and I've shown you almost, if you look at the app, there are almost 20 to 25 images of the tympanic membrane. It's a very important question. They can show you different images of the tympanic membrane and either ask a clinical based question or just an image based question. That's why tympanic membrane is very, very important. And again, another question from the middle ear anatomy. This was a simpler one. See, every lecture that I take, every app, every time I teach, I keep telling you middle ear anatomy is very important. The image based question from the middle ear anatomy is almost always asked. Lo and behold, there is a question from the middle ear anatomy. In the last few years, they used to give a very bad image of the middle ear. The quality of the image used to be bad, and the question is slightly difficult, like sinus tympani. They had asked one sinus tympani a few years back, but this time it was relatively simple. I'm sure everybody got it. This is the image of the ossicular chain, and they point an arrow at the incus, and they asked you what is this ossicle. Straight away, this is incus. There is nothing to talk about this. This one is malleus, isn't it? Luckily, they did not ask you this is stapes. They could ask you the part of the, they can say this is malleus and what part is this, or what part is this, or incus, what part of the incus is this, what part of the incus is this. If they did not ask, luckily, but they can definitely ask such questions. So this is the image where, again, from the PDF file where I've shown you this image of the ossicles, and there's so many images of the middle ear, different walls, different structures. Middle ear, everything is important. I keep telling you this, and that's why we always, for any exam that you go for, middle ear and tympanic membrane anatomy and the images becomes extremely important. I show you a lot of them and in my classes, and I also draw so many of them so that you get a proper hang, because they can show you the same image from different angles. Sometimes different angles the image may look differently, and that's what I do in my lectures. Right. We'll go to another question. A patient had damage of the basilar membrane resulting in hearing loss of the high frequency sound. Which of the following is location of the damage of the hair cell? Now this was again an anatomy related question of the inner ear this time. So 3 questions from the anatomy of the middle ear related. One was about tympanic membrane image, second was middle ear, and third is inner ear. And that's why if you remember, if you have noticed, in my lectures I teach anatomy of the middle ear for 4 to 5 hours in the lectures. In eGurukul lab there is 8 to 9 hours of lectures of the anatomy only from the ear. Ear anatomy is 8 to 9 hours. Why so much? Because so many questions. Out of 19 questions, 3 questions are pertaining to from the ENT I'm talking about. After 9 to 10 questions from ENT, 3 questions are only dedicated to the anatomy of the ear. One is tympanic membrane, one is middle ear, one is inner ear, isn't it? And this is slightly tricky question. Everybody knows, I'm sure, that the high frequency sound we hear at the base of the cochlea, isn't it? Base part of the cochlea, and low frequency sound we hear at the apex of the cochlea. And then you have to know what the structures are, and if you have watched the video eGurukul app, you will know everything. Everything is given there. In fact, that's why I've used 3D image. Remember 3D image, because this kind of questions cannot be answered by 2D image only. That's why I specially prepared 3D image of the middle ear of the mastoid. So if you have not watched those 3D images, the video on 3D images, I've taken a lot of pain to personally construct them and draw them and then teach you from there. Very, very important. Going back and look at the 3D images, they're extremely important. Now we all know modulus is the center point around which the cochlea is coiled 2.5 times. So if this is the modulus, or let me use, if this is the modulus, cochlea is coiled around this 2.5 times. So this is the base of the cochlea and this is the apex of the cochlea. So the modulus area is affected, it affects every part of the tympanic cochlea. Every part gets affected. No particular part. It does not only affect the high or the low frequency, it might affect a wide range of frequency. So modulus damage will not cause only high frequency loss. Helicotrema. This is about modulus. Now, helicotrema, we all know helicotrema is at the apex end of the cochlea. This is at apex end where the scala vestibuli meets the scala tympani. Scala vestibuli and scala tympani, they meet with each other so that the perilymph from this vestibuli can go to the media. So this apex end, and apex end is low frequency sound. It is not high frequency sound. Right? And then third choice was stria vascularis. Now stria vascularis is a membrane that joins the basilar membrane with ricus membrane. It joins the basilar membrane with ricus membrane, and therefore again it is in every part of the cochlea. Stria vascularis is from base to apex. It runs from base to the apex, and therefore once again if the stria vascularis is damaged, you will have wide range of frequency. Like modulus, stria vascularis, same thing. It is not going to affect a single frequency. It is going to affect a wide range of frequency from low to the high frequency. Helicotrema will only affect the low frequency. So what is left? Oval window. Oval window is the correct answer, because oval window is the one through which the sound enters the middle ear. If you have watched the ENT app that I've shown you, let me redraw for you what I've shown in the app. So what I do usually in the app, I draw the middle ear like this. Let's say this is the external ear. This is the external ear. This is the tympanic. This is the middle ear. There is oval window and round window, station tube, and I always draw like this, that your inner ear runs like this. This is what? Helicotrema. Helicotrema, and therefore this is apex end. I just told you helicotrema is at the apex end of the cochlea. So what is at the, this is your oval window. Oval window is opposite of the helicotrema. Therefore opposite of apex end is the base end. This is your base end. So base end lies at the oval window and the round window, and that's why when there is a problem in the oval window, the round window, the base end of the cochlea gets damaged, and base end is responsible for high frequency. So if the patient has a high frequency loss, it is near the basal end, and basal end lies near the oval window and the round window, opposite of helicotrema. Helicotrema is apex, oval window is base, and modulus and the stria vascularis affects all the frequencies, right? tricky questions, but if you watch eGurukul app properly, I'm sure you answer these questions without any problem, right? Next one. A patient presented with ulceration nodule on the lateral side of the nose of 2.7 millimeters. Histopathology image is shown. What is the diagnosis? This is actually a pathology question, but because nose was in it is about lateral wall of the nose or the tip of the nose. I don't know if it is lateral wall or the tip of the nose, and we all know the swelling. It's also called the swelling, which has a rolling margins on the lateral wall of the nose, is most likely a basal cell carcinoma. And in this, histology helps because these are palisading areas of the histopathology of the basal cell carcinoma, which is also called rodent carcinoma. And this is one of the most common carcinoma in the lateral of the nose. And as I said, this is the palisading area. This is the pic from the PDF file of the eGurukul, and this is where I discussed this basal cell carcinoma. And this is the image I've shown you, where you can see the ulceration nodule on the lateral wall of the nose, sometimes on the tip of the nose, even the ala with outrolling margins. And the histopathology part is usually discussing pathology. So I'm sure this is discussed properly because it was about histopathology image. So properly in the pathology recall question, I'm sure. Right? Next one. A 15-year-old presented with nasal blockade and recurrent epistaxis. The nasal endoscopy image is given. What is the likely diagnosis? I don't think anybody will have to look at the image also. Just by looking at the age of the patient and there is recurrent epistaxis, straight away everybody knows that's juvenile nasopharyngeal angiofibroma. Anybody who has studied ENT from any source will know straight away this is the right question. The image is just to assist. There is nothing in the image actually. The question itself is sufficient to correct the diagnosis, right? A juvenile male with epistaxis. See, if you look at this eGurukul PDF file, look at this line. If you can read this line, a juvenile male with recurrent epistaxis, a 15-year-old with recurrent epistaxis, straight away, I keep telling you, straight away the only possibility is juvenile nasopharyngeal angiofibroma. Straight away, simple question, no problem with this. Vascular tumor in the nasopharynx starting from sphenopalatine foramen, we all know this, isn't it? And there are very interesting signs in this. There is antral sign, Hallman-Miller sign, then there is frog face, there is Hondusa sign. So many signs. It's a very interesting disease from the exam point of view. Not very good for the patient. It's a very dangerous disease, but very interesting from the exam point of view. For us, we can frame a lot of questions from here because there's so many signs. It's very interesting. There are so many radiological images and all that. Very interesting. Angiofibroma is, I told you, nasopharynx is very important. Either nasopharyngeal carcinoma. In the last 3-4 years, they've been asking nasopharyngeal carcinoma every exam. And this time they made a change. They asked angiofibroma. Both are in the nasopharynx. There are two tumors of the nasopharynx that are important, carcinoma and angiofibroma. Like I said, 3-4 years they've been asking carcinoma. This time they made a change and angiofibroma. But the point is that nasopharynx remains very, very important for any exam. Right. Next one. A patient with nasal polyp and generalized allergy presented to ENT OPD. Nasal polyp and generalized allergy. This is a very typical finding of a syndrome which is called Samter's triad. Samter's triad is a generalized allergy. So they will have asthma. Asthma is a part of allergy and aspirin sensitivity. Plus, of course, nasal polyp which was given in the choice. So this together becomes Samter's triad. So this was a question about Samter's triad. I don't know whether they named Samter's triad or not. One of the students told me they had mentioned this is Samter's triad or something like that. And so I mentioned the diagnosis of Samter's triad is made. And so which drug has to be avoided? Obviously, if the patient is sensitive to aspirin, you have to, very straightforward question. There are 3 syndromes. If you see the eGurukul app, there are 3 syndromes. One is Samter's triad, what is Carter-Gainer syndrome, and one is Young syndrome. These 3 syndromes, they all from the nasal polyps. 2 of them have bronchiectasis also. And I keep telling you, if you remember, in all my lectures, in this app also, eGurukul app, I told you in nasal polyps, the only thing they ask you is these 3 syndromes: Samter's triad, Carter-Gainer syndromes, Young syndromes. I told you, you can ignore everything else in nasal polyp. You cannot ignore these 3 syndromes. They keep asking, and lo and behold, there's a question of function. So the point that I'm telling you, when we take lectures, we know what they ask. So what we tell you, important topics, you must pay attention to that and read only those topics in the last days of your exams, just before the last days of the exams. It really helps. Like the proof is here, isn't it? Let's go to the next question. A patient presented with pain and swelling below the right side of the mandible that pains during swallowing. swallowing. Okay, the radiograph is shown and most likely diagnosis. Again, it's a straightforward question from the eGurukul app से उठा के दे दिया है ऐसा लगता है ना. So I tell you that if there is a swelling in the submandibular space which increases or pains during meals, during swallowing, and the image also I have shown you, I'll give you the proof. This is straightway duct in the the stone in, this is due to stone in submandibular gland, mandibular gland duct, isn't it? And this condition is called sialolithiasis. I've discussed this topic in the eGurukul app. A lymphadenopathy will not give you the stone like this. It's a soft tissue. This is very clearly a high dense thing like a calcium or a stone, isn't it? Pleomorphic adenoma is a tumor. It presents very differently. And Bezoar's abscess is an abscess which is of the sternocleidomastoid abscess. It's an abscess. It's not a, this is a high dense structure. You can see that. And here is the image. You can see that I've shown you in the eGurukul app of the exactly similar image almost. And this is the topic, sialolithiasis. Again from the eGurukul app, everything is there. If you have read your stuff properly, then I think you should have no problem. It was a simple, fairly simple question if you have read it, isn't it? Sialolithiasis. Okay. And by the way, we have also discussed the pleomorphic adenoma, basal cells, everything is discussed. So you can differentiate. If you know your topics, you can differentiate very easily from one topic from the other. This was clearly image. The main thing is image. This the swelling that in the submandibular area that increases in size and pains during swelling is called mealtime syndrome. Can you, if you can read this, it's called mealtime syndrome, because during meals the swelling increases and pains also mealtime. So there was very clearly a mealtime syndrome with the image. So if you put 2 and 2 together, there is no doubt left that you know the answer. It is sialolithiasis. Got it? Next one. A patient presented with a firm to hard swelling as is shown in the image and no other otological complaint and the swelling is for 3 months, most likely diagnosis. So if it's 3 months, one is it is not a malignancy. Malignancy cannot have a long history of 3 months. And this is a parotid area swelling. This area is the area of the parotid gland, isn't it? We all know. So this is a parotid swelling, and so this has to be one of the parotid swelling, and there are two choices from parotid. This is all, see, malignancy cannot be true because like I said, 3 long history, and abscess of the parotid is not firm to hard. It has to be cystic, soft, and Bezoar's abscess is a different thing altogether. I just told you it's abscess of the sternocleidomastoid. It is seen in CS1, so there is a history of otitis media, ear discharge and all that. So it's pleomorphic adenoma. It's the most common tumor of parotid gland, and that's why the most common disease should be your first diagnosis always, isn't it? So when you see a parotid swelling, the first thing that should come to your mind is always this pleomorphic adenoma, because the most common tumor of the parotid gland. And this is the, see, this is the area of the basals, the Citylis abscess. This is Citylis abscess. See, this is sternocleidomastoid. Can you make out? This is the sternocleidomastoid abscess. Basals, this is Bezoar's abscess swelling is here. This is the area of the Bezoar's abscess. And digastric comes like this. Postibly the digastric comes like this. So this area, if it is an abscess, see this area swelling, where this swelling you see, this have a differential diagnosis. This could be submandibular gland swelling. This could be a lymphadenopathy in this area. This could be a Citylis abscess. Because I'm talking about abscess, I'm just telling you Citylis abscess, the area is this. Of course, you have to investigate and confirm is it Citylis abscess or not. But this is the area. Versus Bezoar's abscess is here. See, this is sternocleidomastoid. Can we count? This is sternocleidomastoid. This swelling is a different area. This is the area of the Bezoar's abscess, and parotid gland is here. So parotid swelling will be in this area. Okay, and Citylis abscess is here. Citylis, this one. So this is parotid. Very clearly, see, this is the area of the parotid gland, isn't it? This is the Bezoar's abscess is here. This is sternocleidomastoid. Bezoar's will be here. Citylis will be somewhere here. Right? So a lot of neck swellings, of course, we have done in our app. These are some of the images that I'm showing from the PDF file, where you have seen so many images of the neck swelling. Of course, neck swelling is a very important topic, but neck swellings are discussed not only in ENT, they are also discussed in surgery also. So it's a combination of surgery and ENT, perhaps in pathology also. So if you have read these subjects, you will not have questions asking any neck swelling. I'm not talking about only this one. Any neck swelling is easy to crack if you know these points. So it was not a tough question, it was a fairly easy question. Then we talk about, this is the image of a patient who presented with a lesion on the buccal mucosa, most likely diagnosed. Straightforward image based question. White is swelling on the buccal mucosa. The most common diagnosis is leukoplakia. This is perhaps a leukoplakia, very common, especially in India, because people, they eat pan, beetle, and a lot of those packets, these mouth fresheners they call them, and tobacco and all that cause. It's a pre-malignant condition, we all know this. And if it is red in color, it becomes erythroplakia. Erythroplakia is reddish in color. Hairy cell leukemia is not, the shape is not. Hairy cell leukemia is mainly on the tongue, and it has a pointed, serrated or pointed look, not this kind of a patch. This is like a patchwork, isn't it? And carcinoma in situ is, of course, it's an ulcer. Carcinoma, will look at it, present like an ulcer or a proliferation. It's like a growth, nodule proliferation. It's like a nodule or a growth or an ulcer. Hairy cell leukemia, like I said, serrated margin. I'll show you the image of that. Leukoplakia and erythroplakia, they look very similar. The color is different. Leukoplakia is whitish, like this one is whitish, and erythroplakia is reddish. I was told that the image was perhaps a leukoplakia. That's why I've used the image of the leukoplakia. See, this is hairy cell. This is a hairy cell. You can see this serrated margin. Can you make out? And this is, of course, leukoplakia, which I've shown you just now. Right. And the last image, that question from the ENT that I've got, a patient was unable to blow cheek and there was dribbling of saliva from the same side. What is the probable nerve affected? Very clear cut. If you cannot blow all the muscles of the face, these are muscle problem, the facial muscle problems. So if the facial muscles are defective, the only nerve that supplies the facial nerve, the seventh nerve. Fifth nerve supplies sensory on the face. Sensory of face is the fifth nerve. And eighth nerve is for hearing and balancing. Eighth nerve is for hearing. And 12th nerve is related to movement of the tongue. It supplies the tongue muscle, so it affects the movement of the tongue, isn't it? This is not about tongue movement, it is cheek swelling and dribbling of saliva. So that clear. This is one of the most common thing that happens in facial palsy. Either they'll see the eye is not able to close fully, or the saliva start dribbling. That is the first thing, because patient cannot see the face. When you have facial palsy, you can't see the face, isn't it? Usually. So you cannot make out the asymmetry. So either the patient feels that they cannot close the eyes properly, or the saliva start dribbling. That is the first thing they usually notice when the facial nerve, because most common cause of facial nerve is Bell's palsy. So there is no other cause, there is no other history, nothing. So suddenly the patient starts feeling, I can't close my eyes, or this saliva start dribbling from that side, and that is the first thing that warns the patient that you still really have a problem. And then they start seeing themselves on the mirror, and then they notice the asymmetry and they rush to the doctor. Facial palsy. Again, a very simple topic, very common topic. I keep telling you that out of the 12 cranial nerves, from the ENT point of view, facial nerve is the most important nerve. How many times every lecture I tell this. I told you, if they'll ask you a question from the cranial nerve, from the ENT point of view, it is going to be the facial nerve and no other nerve. Didn't I tell you this? And so facial nerve is here. So the point is, guys, that this is the PDF file from the same topic, facial nerve. The point is, guys, that the questions, they don't get asked from outside of the main notes. So concentrate on the main notes, and you are going to be able to answer not only ENT, all the subject I'm talking about. You'll be able to answer most of the questions. Okay. So thanks for watching. God bless you. I hope you have done very, very well. We're waiting for your result with a lot of excitement. We are almost as excited as you guys are. So let's hope and keep our finger crossed and hope for the best. We'll meet you again once the results out. Thank you. God bless you.